I'm going to start out just by talking about peritoneal disease by modality and different pathologies and how they manifest. So some basic stuff here. And then we'll talk about, after those modalities, I'm going to, as I mentioned, go over a differential for both neoplastic and non-neoplastic things, really focusing not on the common things that we see every single day, but the stuff you'll see maybe a little less often, but you can really make the difference if you're able to recognize these. Some of them when you combine it with other findings or the patient's clinical history. So just to start out, what is the peritoneum? Well, it's this enclosure of the abdomen. As we know, there's the visceral and parietal layers that kind of wrap all the way around, and it encases this potential space, the peritoneal cavity, which I've put in purple here. But it's really this yellow area that I really want to focus on, the subperitoneal space that is deep to that mesothelial lining. That's where all the action is really happening, and sometimes it breaks through into the peritoneal cavity, but most of the time we're talking about that subperitoneal space. And that can be a bidirectional area for gaining access to the retroperitoneum and vice versa as well. So it's really the highway of where all this stuff is happening. Here's just an example. This is a young, unfortunate transplant recipient who had PTLD, and you can see the infiltration on this gross at autopsy, all this tumor infiltrating into the mesentery and actually along all the serosal surfaces. And that's what we're seeing when we're talking about serosal bowel wall thickening and mesenteric infiltration and so forth. So that's just an example of that. So let's run through how can this manifest? Peritoneal pathology, there's not a whole lot it can do, right? You can have fluid or ascites. You can have pneumoperitoneum. You can have a soft tissue, either infiltration, as I just showed you, or more mass-forming lesions, calcification, of course, and then foreign bodies. We're not going to talk about the real common things that we see every day, just the uniform run-of-the-mill, and not just the usual peritoneal carcinomatosis from either a ovarian or GI primary. And of course, when I say ovarian, we really mean fallopian tube, typically for most of those serous carcinomas, which I will mention. And we're not going to talk about postoperative collections or cirrhosis with portal hypertension. That's pretty much, I think we're all aware of those things. But I would like to remind us that early disease in the peritoneal cavity, whether it's a primary process or metastatic, it's often missed. So if you go back, when you think you're all proud of yourself, you detected some peritoneal process, if there's prior imaging and you go back, often there'll be a really early manifestation that maybe is below our level of detection. But we really have to be aware of those misses. Sometimes they lead to a really prolonged delay in diagnosis. So we really want to be aware of that. All right, let's just start with the basics first. So radiographic evaluation, we know plain films or radiographs are great for pneumoperitoneum. Whenever I see a case, and this is the supine and upright companions here, whenever I see free air on an upright radiograph, as we see on the right, I always go back and look at the supine film just to see, would I have called it? In a case like this, obviously we're seeing regular sign, we're seeing both sides of the wall, bowel wall delineated by gas, both in the lumen and the peritoneal cavity. Here's that, we'll talk about the Doji cap sign in the hepatorenal fossa, and then the continuous diaphragm sign here at the central tendon there. So there's a lot of good findings that, in this case, is quite obvious, but it's really when it's not so obvious is where we want to be able to nail it. And this is just another case where there's massive free air. We can see it on a supine film, and that's how we're getting that Wriggler sign. Of course, you're looking at a CT, and we're able to silhouette the bowel because we have gas on both sides. Beware of, like an ileus where bowel loops are right up against each other, and you're just seeing luminal gas in both cases, and not, one side being peritoneal gas. So just be aware of that pitfall. Of course, if the patient's not able to get an upright or a decubitus, you can do a cross-table lateral like this in a pinch. If there's just no way to move the patient, you can still get some sort of correlative imaging to try to be more sensitive. This is a nice call by one of our residents. So it's upright chest radiograph. There's nothing under the right hemidiaphragm, but sometimes air will just be sitting over there under the left hemidiaphragm. And this was a nice example of a perforated gastric ulcer. And I just point out, here you can see that there's gas in the lesser sac. And when I see that, I'm thinking gastroduodenal ulcer first, because you typically won't get gas entering the lesser sac and then seeing it elsewhere. So it'll always start there typically. So that's why I look very hard. You don't see the ulcer isn't super obvious here, but it's there. And this case was actually miscalled. You can see that there's some foci of gas in the greater peritoneal cavity, but because of this inflammation, this was initially called as, well, maybe a colitis or a diverticulitis, because you see inflammation along the colon. But again, that lesser sac gas should have made us think first about a perforated ulcer, which again is still the most common cause of unexplained pneumoperitoneum in the ER. So always think ulcer first. Other causes of perforation certainly can happen. But with diverticulitis, it's not very common in an immunocompetent individual. It happens, but not very often. Here's that central tendon, the continuous diaphragm sign. So people call it the cupola sign. This is the dome in Florence here. It kind of looks like a cupola, I guess, but it's because air is outlining that central tendon of the diaphragm. And then here's just looking at that gas in the hepatorenal fossa. So we're seeing gas in two different cases here, and it's located in that little recess between the liver and the kidney. That's essentially Morrison's pouch. But it's called the Doge cap sign because of the doges, the rulers of the Venetian city-state. Not to be confused with the Phrygian cap sign, which are worn by freed Phoenician slaves. Now, I don't know why we know this stuff in radiology, but we talk about it all the time. Anyway, what about massive ascites? This is just radiographic basics, but when you see the bowel loops are sort of displaced centrally and there's increased opacification, this is a radiograph. On the right is a CT scout where I think you can see it better, where that colon is really centralized, and it's not because, it could be all just abundant fat, but obviously in this case, it's due to massive ascites that's displacing bowel centrally. So, these are radiographic findings and then ultrasound, of course, is great for guiding paracentesis and for outlining that same finding. And we'll talk about ultrasound in a little bit. In terms of calcification, another thing we can identify in radiographs, these are two patients with peritoneal echinococcosis, so hydatid disease that ruptured from the liver, spilled into the peritoneal cavity, and you can get multiple rim calcified lesions. This looks almost like just a degenerated fibroid, but it was a large kind of coccal peritoneal mass. This is a little more relevant, I think, to our practice. At first glance, this almost looks like dense stool, and this is a scout for the CT. When you look at the CT, all that density, I'm going to change the windowing here, that actually is in the peritoneal cavity. This is dense calcification, and when you see that, especially in a woman, you're going to think about high-grade serous carcinoma, or low-grade in the case of, calcification supposedly will mean a better prognosis with these tumors, but don't be confused. Sometimes it'll mimic stool when you see this kind of tumor calcification in the peritoneal cavity. And then we all know about foreign bodies. Here is a retained surgical sponge with that linear appearance. Pretty easy on radiographs, and I think a lot easier on the radiograph than CT. So, for example, this patient here has multiple retained sponges, but this looks like this mottled gas, which is the gossipoboma or textiloma. Actually, I'll show you the scout in a second, but this looks like stool, and you can your eye doesn't really notice those densities nearly as much as when you look at the scout. You can see there's 1, 2, 3, 4, or at least 4 or 5 retained sponges here, and it really can look like a colon-containing stool. So really, I think glancing at the scout should be in our search pattern. Just in general, we have a whole paper on how the scout can help find things. It's better at bowel gas pattern, of course, than the CT is. It puts it all together in one quick look. So I would recommend that we still keep that in our search pattern. I try to. Unfortunately, our new hanging protocols don't include the scout anymore, so I have to manually pull it down every time. Let's talk about ultrasound. We know this is used to guide paracentesis and biopsy, pretty obvious. I'll show a lot of pathology along the way. This is a patient that just happened to have peritoneal sarcoidosis. That's actually a very rare manifestation of sarcoidosis. And then this patient who I did this diagnostic paracentesis on actually had very high eosinophilia. This is eosinophilic peritonitis. It's the serosal form of eosinophilic gastroenteritis, just involving that outer layer. And it can lead to what looks like, both of these look like carcinomatosis, right? There's infiltration of the omentum, and there's fluid, unexplained. You think, first this is carcinomatosis, but there are a lot of things that mimic carcinomatosis, and it makes life interesting. But here are just two examples. And way back then, this patient actually had a peritoneal biopsy, an open biopsy, because they didn't really believe the results that we were getting from the diagnostic paracentesis. Here's omental caking. This is actually not carcinomatosis, but lymphomatosis. Similarly, if you do have this kind of involvement with a sarcoma, you'd call it sarcomatosis, not just to be precise, right? They're not carcinomas if they're a sarcoma or a lymphoma, but this is lymphomatosis. And I'm basically showing this because we use the CT to guide the ultrasound where to go for biopsy. We sometimes have to use landmarks because you have to be comfortable. Ultrasound, sometimes they'll come back to me, the sonographer will come back and say, oh, I didn't see any tumor. But they're really just not seeing this uniform. You have to, really figure out what layers you're looking at, and it can really look isoechoic to things like intra-abdominal fat and so forth. But if you really use the CT as your landmark and decide, let's look here, yes, that thickening is the caking. Here's just another example. This was, I believe, a case of ovarian cancer, just run of the mill. And again, we want to use. I always tell the sonographer, okay, look, look above the belly button. Relative to the umbilicus, I'll tell them where to go. Go left and up, and look around there, and you should see it. And we do a ton of omental biopsies, and we've written papers on that too. Mesenteric masses. This is a patient with fibromatosis or desmoid tumor. Obviously we'd use ultrasound, not CT, to do. You can do a real-time biopsy in seconds. And then ultrasound's also quite good, of course, in the emergent setting for hemoperitoneum. This is a patient, not surprisingly, that has a ruptured ectopic pregnancy. You can see that echogenic hemoperitoneum. But ultrasound isn't great more for the traumatic hemorrhage that's going to be between mesenteric leaves. For example, this patient had a negative FAST scan, but that's because this bleeding, which is actually active extravasation, is within this mesenteric leaf, and there's no free fluid per se. So CT is definitely going to have advantages over ultrasound in terms of some of these locations in the trauma setting. And then ultrasound, we all know, is better at depicting septations over CT. This looks like fairly simple peritoneal fluid here, but there actually were a bunch of septations in this patient with benign cystic mesothelioma. The more you look, you can see lots of septations. This is another case where it looks like it's a big single loculated collection, no problem. Drain it put a drain in there. When you look with ultrasound, there are tons of septations in this loculated rind. We can see the rind by CT, but you can't make out all those internal septations very well. And that IUD should make us think, oh yeah, this is actinomycosis, and that's actually what this proved to be, actinomycosis, with kind of this thick multiseptated abscess collection. But CT, I'm going to focus mostly on CT now for the rest of the talk. This is really the workhorse, right? This is what it's, what we do all our oncologic detection, staging, follow-up. This is how we put it all together typically, and use in the trauma setting and the oncology setting. And I believe positive oral contrast helps with detection. It's been shown to help with mesenteric masses and peritoneal findings. If you don't want it too dense, but if you have the right density of positive oral contrast in the oncology setting, it's quite good. I'll show some examples along the way. So this is the kind of thing we're looking for, like early disease, this little nodularity, kind of reticulonodular infiltration. This is a patient with unsuspected early peritoneal mesothelioma. And this is what it looks like, when they go in laparoscopically. We're going to miss some of these sub-centimeter little early deposits. But if we're lucky enough, we'll be able to see just enough to make the diagnosis. But admittedly, there's no imaging technique that's sensitive enough for the sub-centimeter lesions in general. So we do the best we can, and CT is pretty good, but it's far from perfect. And then any tumor that gains access to the peritoneal cavity, of course, can cause either carcinomatosis or, as I said, lymphomatosis, et cetera. This is an adenoid cystic tumor, a minor salivary gland tumor, I think of the parotid or something, but a very slow-growing tumor, but you can get carcinomatosis from anything as long as it gains access. And then as Michael showed earlier, this is a nice example where we're seeing some subtle differences in density between this caked area and the fluid. There's loculations, there's probably indentations and scalloping up high, but you can actually see the primary appendiceal tumor in this case. So you can put it all together and say, oh, this is a mucinous appendiceal primary pseudomyxoma. Here are other cases of pseudomyxoma. You can get that scalloping. You can get septations with or without calcifications that you can see nicely here, the parietal thickening, and then these septations with calcification. And this is, the jelly belly, of course, that we're all familiar with. This is a complex solid and cystic appendiceal mass. Here that they looked at endoscopy, they just thought, oh, this is some sort of submucosal tumor. Obviously, they can't really put it together like we can with CT. And this proved to be another appendiceal primary. This is a malignant tumor, and you can see there's some very early peritoneal spread. So this is what very early carcinomatosis. If those cells are viable and can spew out mucin, you eventually get these loculated mucin-filled collections of varying attenuation with or without calcification. And anyway, that's pseudomyxoma. We all are familiar with that, I think. Let me just show you some examples of subtle early peritoneal recurrence or of disease. This is a patient with a stage 1 endometrial cancer. So, nice oral contrast opacification. And right here in the right lower quadrant, there's a little about a 1 centimeter nodule. That's the only finding of disease in this patient. And I think without oral contrast, that might hide easily with the enopath. So I know the people at Mallinckrodt are like, oh, we don't use oral contrast. But we do, and we love it. And especially for oncologic imaging, I think you're going to miss things without it, no matter how good you are. And we were able to make a ultrasound guided biopsy of that lesion to prove early disease. This is what the patient looked like, unfortunately, about a year later. Now, this is classic peritoneal carcinomatosis with obvious massive caking, parietal and visceral involvement. And, you don't need any oral contrast, obviously, to make that detection, but you don't know what you're getting into at the beginning. Here's another case. This is a GI stromal tumor undergoing surveillance. And I think it's pretty hard to detect. There's a subtle implant here. If that were the only lesion, that would be, I think oral contrast would have helped. There are other masses, though. This is sort of all these little cannonballs of GI stromal tumor. And this is what the patient looked like a year later, almost completely, there's tumor everywhere. It's hard to even find bowel. This is the kind of thing we're looking for, and sometimes we can intervene, and other times, it's just too late. This is an example of a patient with a metastatic breast cancer. So, that signet ring type morphology with infiltration of the stomach, but also peritoneal disease, endomental caking. This patient actually had a negative endoscopy, right? We saw the thickening, but it's deep to the mucosal surface. So they'll sometimes look like totally normal if it's not significantly narrowed down the lumen. They may just call this normal, which they did, but CT can kind of put that all together nicely. And then complications we can detect. This is a patient with a sarcoma. So this is sarcomatosis, and this patient was this is an angiosarcoma. So actually had a risk for bleeding. This case not only progressed, but it caused intra-abdominal, there was hemorrhage within this metastatic disease. It was a horrible case because it's very hard to treat, obviously, but this is hemoperitoneum in the setting of primary peritoneal angiosarcoma. In terms of in the ED, patients that have Crohn's disease and have a flare, we're obviously going to typically use MR enterography. But if they come to the ED very sick, we don't do an enterography study. We just do a routine CT with oral and IV contrast. And in this case, you can see that those contrast-filled loops are obviously disease. This patient has very severe, compared to the flare they had before. This is now very severe disease. And this is interloop abscess that, obviously I think is easier to detect because of the oral opacification. But we probably would have been able to tell that this is extraluminal relative to those thickened bowel loops. So you can probably get away with it. In terms of unexplained abdominal symptoms, this harkens back to what Michael was showing. This was a patient from northern Wisconsin who was fond of our Friday night fish fry, but had this aggressive-looking peritoneal mass. But in the center of it, I hope you can see that linear density. And so not surprisingly, this is going to be, this is a fishbone perforation that perforated the jejunum. Now you can see it better on that coronal. It caused a really ugly-looking aggressive mass. So if you don't identify that foreign body, you might mistake this as a very aggressive tumor, maybe some other aggressive inflammatory process. There's the specimen radiograph, and that's how I came upon this study. That radiograph came through, and I'm like, oh, that's cool. And then I went back, and it was an outside CT that showed the fishbone. Iatrogenic complications. So this patient has a ruptured spleen. Obviously, came to the ED dizzy. This patient did not need oral contrast, but again, we don't know before. But it was stable enough to have a routine scan, but has massive hemoperitoneum. Sometimes it's hard. This was non-traumatic, but when you ask the patient, what have you had recently? About a week ago, this patient had a colonoscopy, and so they removed a tiny 2-millimeter polyp, but they also banged into the spleen and probably traction injury on the phrenicocholic ligament. I've seen over a dozen cases of this. It's a not well publicized complication of colonoscopy, but splenic injury. It's felt to either be due to just ramming into the spleen bluntly, or more likely traction injury with that phrenicocholic ligament causing either a subcapsular or frank hemoperitoneum. And we've written up a whole series of these cases in the past. So just if you see unexplained splenic rupture and it doesn't look like they have lymphoma, leukemia, or something, one thing you could ask, well, have you had a colonoscopy in the last 2 weeks? Because it's often delayed. It can take up to 10 days, I think we've seen people present. So just be aware of that. Here's peritoneal calcification. So we're seeing it even going into the umbilical hernia. And the key to the diagnosis here is of course, this peritoneal dialysis catheter. So these people get encapsulating peritoneal sclerosis, often with calcification. We'll talk about that a little bit later too. In terms of MR, I don't want to go into great detail for this imaging modality, but pitfalls exist, but it's generally analogous to CT. Otherwise, it has some advantages, some disadvantages. Here's a patient with serosal implants on the liver. Obviously, on one of these sequences, it looks sort of ISO to liver, but you still wouldn't miss this. Becomes much more obvious on more T2-weighted sequences here, and this is just serosal implants. Another case of desmoid tumor or fibromatosis, just looking at it on MR, and there's the CT correlate, so very, very similar. Here's a patient with peritoneal sarcoidosis on MR, and it just looks like, it's very nonspecific. It's infiltration of the omentum. This is a very uncommon manifestation of sarcoidosis, as I mentioned, but I'm going to show you lots of different manifestations of some common, but a lot of uncommon things. One thing that's bailed me out is diffusion weighted imaging, because sometimes the bowel, we just, there can be kind of motion or artifact, or, you don't really get a good sense of what's going on sometimes with the peritoneal cavity and adjacent bowel. But here, I think with diffusion, we can see, there are some restricting nodular soft tissue masses. When you go back then and look at your other sequences, you can convince yourself that those are real. And sometimes you kind of gloss over the peritoneal cavity. But this was a patient that had an HCC that had presented with hemoperitoneum. This was the original CT. And so unfortunately, they just seed their peritoneum when they present with that rupture. And now this is what the patient looks like. So on CT, I think we would never miss this. I have seen it missed more often on MR just because we're just not used to looking, I think, for carcinomatosis, although some centers are using it for pseudomyxoma and so forth. I actually don't think it's a workhorse modality. There's a case from Sanjeev, actually, from Mallinckrodt. This is a patient with colorectal cancer. They missed these implants, but these were restricting, and you can even do some fusion imaging if you want with the diffusion and anatomic scans, and maybe not miss that these are actual implants. And then PET evaluation, we've heard a little bit about PET. I don't read PET, but I do want to at least be able to open up a study and make sure I know what I'm looking at. The functional assessment obviously will improve on our anatomic-only imaging, and so I think we do quite a good job when we look at things like PET-CT or PET-MR. Here's just an example of a patient. We're seeing typical peritoneal carcinomatosis. It can be quite exquisitely sensitive. There's a patient with melanoma. Maybe you detect that little nodule in the left upper quadrant, but when you see it intensely FDG avid, you're probably dealing with a peritoneal disease, and that in fact was the case. But beware, there can be misregistration, right? As Tyler mentioned, there's issues between these fused images. On one level, we're seeing this GI stromal tumor, but this was actually called GI activity on the read because somebody was probably reading off the fused images here and didn't notice the next image down. There was actually a correlate for that, and it wasn't just bowel that was lighting up. So that was a GI stromal tumor. This is a young patient with peritoneal lymphomatosis. It's so low attenuation, you might almost think, is that fluid? Is that high attenuation fluid? But then you look at the metabolic activity, and that's all solid tumor that we're seeing there. In terms of intraoperative evaluation, this is still the gold standard for small implants, as I mentioned. We're just not going to pick up these tiny little dustings, these little sub-centimeter foci, no matter how we're nowhere near the spatial resolution. Maybe with functional PET and anatomic imaging, someday we can get there, but we're just not there yet. So when we're talking about carcinomatosis and this approach with cytoreductive surgery and HIPEC or hyperthermic intraperitoneal chemotherapy, we really want to be able to stage these patients well and make sure we're not only staging but following up and identifying sites of disease. Unfortunately, neither CT or MR or PET is really going to match intraoperative evaluation, and that can really, of course, matter for early disease. So we're still working on our best modalities, but it's really quite tricky. And I'm not going to go over. I think I'll probably end here because I have a lot of differential cases. We've written over the years many review articles. Let me just show you the list. It's daunting, so I don't think you want to get into this late in the day. These are just the primary neoplasms, both benign and malignant. Things like serous carcinoma, mesothelioma, lymphoproliferative diseases, then a whole host of mesenchymal tumors to think about. I wish I had more time to go through it, but I'm not going to torture you this late in the day. And then same thing we have. In fact, let me get to I'll show you what you're missing here is all these. This would have taken quite a while to get through, but I want to show you the non-neoplastic list, which is also quite daunting. But anyway, I'm a collector of these cases. They're fascinating. There are a lot of clues that can lead you to the diagnosis. And so a lot of these cases you might be able to suggest or narrow. Okay, good. This is what I wanted to get to. So these are the non-neoplastic conditions. This is an even more daunting list, right? We have systemic multi-organ. I mentioned eosinophilic peritonitis. We have amyloidosis, extramedullary hematopoiesis, so on and so forth. Tumor-like conditions that can really mimic cancer. IgG4, endometriosis, so on and so forth, atypical infections, a lot of fascinating things. And even the fat-based conditions, I think, are very interesting. And fat is your friend, in terms of making a more specific diagnosis. So in conclusion, radiology plays a very important role in peritoneal disease. So be aware of very early findings in isolated disease. Don't miss it. Sometimes if we put our thinking cap on, we can use clinical and other imaging data to narrow the differential diagnosis. And I think that concept of subperitoneal involvement is important. That's how things really spread early on. And knowing the imaging findings and the strengths and weaknesses of the other modalities. So with that, I'm going to have Tyler come back up. Thank you for your attention, for those of you who made it this far.